Yeah, so my name is Qing Yan. I'm a professor of medicine and physiology at UCI. I also serve as a director of the UCI Diabetes Center. I'm a physician scientist, seeing diabetic patients and other endocrine patients. But my lab studies diabetes, specifically why people develop diabetes, and try to figure out the ways to treat diabetes. Now, today, I'm going to give you a quick overview of diabetes and eye health, and mainly to give Dr. Browne some background so that he can give you more about eye conditions with diabetes, management, prevention type of things. So the outlines will be a couple of facts. I think most of you know those things, but just to reiterate how important it is, the numbers you will see, some of the numbers are really astonishing. And the second is why are diabetic patients prone to eye diseases, the mechanisms for eye conditions with diabetes. And also, finally, I will give you a couple of slides on how to prevent the diabetes-related eye problems. So factor number one, I think even you are not a researcher, you know there are a lot of diabetic patients around the country in the world. In America, it's about 11% of population. And one third of them are not really diagnosed with diabetes. They're just walking around with high sugars. And it's kind of dangerous because those people will develop complications because they are not managed. And we have more kids becoming diabetic right now with obesity and overweight conditions. And for older people, the diabetic rate is much higher at around 30%, meaning almost 1 in 3 would be diabetic if you are older than 65. And almost 50% of people aged 65 older would have pre-diabetes. Those are the candidates for diabetes in the future. So there are a lot of diabetes, pre-diabetes walking around. So probably most of you would have friends, neighbors being diabetic. Now, number two fact is diabetes is a leading cause for blindness. This is a paper actually from Taiwan, published in JAMA, which is a very good scientific journal, showing there are, this is a United States study, 26% of those with diabetes have a condition, retinopathy, that's the most common diabetic eye condition. And there are around 5%, 1.8 million of them had, that's in 2021 data, had a vision-threatening diabetic retinopathy. A lot of people would become blind if left untreated. And also there are some racial differences here, more in Black and Hispanic people. The rates are higher for those vision-threatening diabetic retinopathy. So it's a major issue for diabetic patients. If you can imagine, if you lose your vision, your life quality will be reduced a lot. In addition to what is called retinopathy, and diabetes is also associated with other eye conditions, including cataracts and open-angle glaucoma. So I think you know what cataracts is, and diabetic patients have 2 to 5 times more likely risks for developing cataracts, and twice possibility to have what is called open-angle glaucoma as the increased eye pressure. So retinopathy is most common, but people also are more prone to other eye conditions, including cataracts and glaucoma. So this is a very important slide. Actually, 90% of blindness in the US adults caused by diabetes is preventable. This is very important. If you control diabetes well, if you do the screening, make sure you manage the eye conditions with proper treatment, 90% of the blindness can be prevented. So that's why it's very important to send the message to the diabetic patients, control your diabetes, see eye doctors, make sure prevent it from the happening. If it happens, then make sure you don't progress to severe conditions. So then the next question or point I want to make is why diabetic patients are prone to having eye conditions. So it has to do with, of course, high sugars, also risk factors, including high blood pressure, high cholesterol, smoking type of things. So I'm not going to do kind of scientific talk to give a lot of details, but this is just a structure of eye. I think Dr. Browne probably can give you more detailed structural education. But basically, this is your pupil lens. This is called iris, cornea. This is front of the eyes. And the retina is here, kind of bottom of the eye layer. These are actual nerves. So, and the light gets in, and the retina part convert the message, basically, signal to this kind of optical nerve, then to the brain so that you can see things. And when you have high sugars, these nerves will be damaged through multiple, signal pathways. This is more kind of scientific. One is called oxidative stress that also induce the inflammatory process. These are all, so the nerves kind of inflamed. And what happens, they die. And so, they cannot do their job to, send a message to the brain to process so that it can see things. This is a direct damage to the retina nerve type of things. This is the main thing. Second mechanism is very, very important, blood vessel. The bottom of eyes, because, nerves or the structures need blood supply, need oxygen, nutrients all through the blood vessels. And the blood vessels, are mainly composed of those cells called endothelial cells. There are other structures too. Those cells are actually very prone to high glucose, high sugars. We could, in the laboratory, isolate those endothelial cells. If you culture those cells with low glucose versus high glucose sugar, basically, you will see a lot of dramatic changes to those cells. The cells become sick. Again, has to do with a lot of signal pathways and oxidative stress, inflammation as seen in those nerve cells. And also generate some growth factors called VEGF. And then what happens is those growth factors would promote those small vessels to grow, abnormal vessel grow, because those are growth factors. So when those large vessels are damaged, if this pathway is not going through, there are some small vessels will be growing. And those vessels are very fragile, easy to leak things, bleeding type of things. And this is a normal retina you can see. This condition is called a non-proliferative diabetic retinopathy. It's kind of early stage. You don't see new vessels, but you see some bleeding, see some what is called aneurysm. Those vessels are kind of become a balloon, and then it's easier to be broken and causing bleeding. But then more severe condition is called a proliferative diabetic retinopathy. You can see there are new vessels. Those vessels are thin, fragile, and easy to be damaged. Then it causes large bleeding and causing major issues. So again, there are a lot of mechanisms there, but the key factor here is glucose. When you have high sugars, then the initial big vessels are damaged, and there are growth factors will be made, the new vessels grow, and then you have more issues, become a vicious cycle. So you can imagine blocking the first step, meaning high glucose, high sugars, would be important prevent the progression of the retinopathy. Now, then, how do you prevent the condition? As I mentioned several times, diabetes control is the most important thing, and other risk factors, including high blood pressure, cholesterol type of things. And early detection screening is important too, and then treatment is important. So diabetes control, the question is, you know, for diabetic patients, what would be the sweet spot, the level you want to be to prevent the retinopathy, the eye condition. So back in 1997, American Diabetes Association, based on the studies, decided that diabetes diagnostic criteria actually was based on the development of retinopathy eye condition. There are 3 lines here. This is a bit old slide. Stands for fasting glucose, 2-hour sugar after you eat. And this is important one called A1C, which reflects average sugars in 3 months. If you are diabetic, you must know these numbers, these terms. So you can see, let's give a rough, let's look at the A1C first. You can see the A1C, which is kind of this line. When the A1C is below 5.6%, the incidence of retinopathy, this is a percentage, it's very low, it's baseline. But you can see when the A1C goes beyond 5.6%, the development or the incidence of retinopathy increases quite dramatically. And this is a linear increase. So higher glucose sugar levels you have, more retinopathy. All right, so it's quite a clear cut pattern here. And scientifically, they calculate the way, and then ADA decided that 6.5% would be the sweet spot for the diagnostic criteria for diabetes. But the truth is, if you just look at the retinopathy, lower A1C is always better, right? So if you can control diabetes below 5.7%, your incidence for retinopathy is lower. Of course, it's a very tricky situation when you manage diabetes. You really have to manage comprehensively, because if you control diabetes too tight, the chance to have low sugars called hypoglycemia increases. So it's a trade-off between preventing the complications, including retinopathy, and preventing the low sugars, which can be also dangerous. So what I would say is, if you don't have low sugars, control diabetes, lower sugars, always better. Of course, you cannot have low sugars. So that's a diabetes control there. And, we always say 4 pillars for diabetes management: dietary control, exercising, medications, and monitoring is very important. And, we are kind of in a bit fortunate situation right now. We do have a lot of medications for diabetes management right now. This is a bit scientific. I'm not going through the details. There are medications managing the pancreas, the brain, the kidney, muscle, fat, liver, and the intestine. So we have medications targeting these different organs for the diabetes management. But in terms of the eye conditions, are there medications better than others? If you worry about your eye condition is your priority. So there is a type of a medication called SGLT2 inhibitors. If you are diabetic, you probably are on one of these medications called Farxiga, Jardiance, Imcana. These medications act on the kidney, which opens the kidney channel type of thing. so that the sugars actually can dump to the urine instead of stay in the blood. So this is a Taiwan study. They compared different kind of medications to see what kind of diabetic medications are better than others in preventing the diabetic retinopathy, especially those side-threatening retinopathy. It turns out that these type of medications, SGLT2 inhibitors, are better than others. I just showing two figures, there are more figures there, in terms of preventing the diabetic retinopathy. So if these type of medications are also effective in preventing the heart conditions and kidney conditions. So they are becoming the first-line treatment for diabetes. So I think if you worry about complications, I would encourage you to talk to your doctor about these type of medications. They are not only good for the heart, kidney, but also better to prevent the retinopathy. Now, I know a lot of people know these medications getting very popular. It's ads everywhere, weight loss medications, Ozempic, Wegovy, Mounjaro, Zepbound. Those are called GLP R agonists that promote weight loss, treat diabetes, good to the heart. New data showing also good to the kidneys. But there are some data showing these type of medications actually may not be good to the eyes. There are reports showing that some patients after the treatment, the diabetic retinopathy got worse. There are some controversies. Other reports did not show that. So I think more studies are needed to see whether these medications are protective or more worsening. Right now, there are just reports showing they may worsen your diabetic retinopathy. And just a recent paper also showed that people taking Ozempic type of medications may have higher risk to develop a very unusual condition, rare condition called Lyon, NAION. If you have questions, probably ask Dr. Browne about this condition. It's a form of blindness caused by optic nerve disease. So again, there are controversies. This study is kind of scientifically called retrospective. It's not conclusively demonstrating these medications can cause this condition. But there are some literature there. I think the bottom line is if you have vision changes when treated with these weight loss medications, make sure you talk to a doctor and see the eye doctor. So in addition to the A1C or diabetic management, these also, you can see the progression of the diabetic retinopathy. When your A1C is above 7%, the chance to develop a retinopathy is much higher than if your A1C is below 7%. Of course, if you can manage your A1C lower than 7%, the incidence or development will be even lower here. But you can also see here blood pressure has impact on retinopathy. When you have high blood pressure, your retinopathy goes up. And when you have high cholesterol, you're above 100, your retinopathy goes up. So this is kind of overall management of risk factors. Sugars are the most important thing. Of course, it's very important to control your blood pressure and your cholesterol. So then the early detection is very important. ADA recommends yearly exam or when you have changes to the symptoms. You know, the problem is only half of the people are doing this. You know, half of people are not really doing the regular eye exam. And if you do the early detection, studies show that you can reduce the vision loss by more than half. 50%. So it's really important to screen for the disease. And these are also other numbers. Again, they're showing different eye conditions, different severities. And, you know, if you detect early, treat early, I'm not going through this in details. Basically, your risk for severe disease will be decreased quite significantly. And your blindness chance will be lower too. if you progress to the severe condition, then your risk to have blindness is much, much higher in 2 years. So it just illustrates the importance of screening and treating early there. And I'm not going through this in details because this is more kind of Dr. Browne's field. So treatment for retinopathy, it will be laser injections. I mentioned the VEGF, which is a growth factor promoting the vessel growth. And we have medications for that, targeting that growth factor to treat the retinopathy and other surgery if it's severe enough, just potential treatment. So the take-home message to end up is retinopathy is usually not reversible, unfortunately. Therefore, prevention is really the key, and the diabetes control is important. Risk factor management is important. Early detection and treatment, very important to prevent the blindness. I'm ending here and turn the podium to Dr. Browne.
Yeah, thank you, Dr. Yang, for that really wonderful introduction to diabetes and diabetic retinopathy and the various ways that diabetes kind of can be controlled and prevent the complications that arise from it. I'll just give a brief introduction to myself, but I think that maybe before we transition, I'll just answer pose the first question to the two of us: is how long will it take for untreated diabetes to cause eye disease? And so the typical rule is, there's no hard rule, but generally speaking, we think of it taking about 5 years from the onset of diabetes for it to start to cause diabetic retinopathy. And that's based largely in type 1 diabetics, people who develop diabetes earlier in their life when they have a seminal diagnostic event. And it takes about 5 years from that diagnostic event before they develop diabetic retinopathy. People who develop type 2 diabetes are often diagnosed probably well after they actually develop type 2 diabetes. And in that case, it's still going to be about 5 years from the time they develop diabetes, but oftentimes they can be showing up to a clinic like mine when we'll be making the diagnosis of diabetes and then sending them over to primary care and endocrinology for their care. Is that a fair summary there, Dr. Yang?
Yeah, great. So just to point out, as you mentioned, the second point, that type 2 diabetes, a lot of people don't know they are diabetic. I mean, you can in my slide, 1/3 of them don't know they are diabetic. So they kind of they see us, and when we refer them to the Dr. Browne ophthalmology, they have conditions already. Actually, it's quite common. So screening for diabetes is also a major thing here.
Great, thank you so much. So just to give everybody a brief introduction, I'm Andrew Browne. I'm one of the retina specialists. I take care of people with retinal diseases and surgical diseases of the retina. I do that about 2 days a week, and then 3 days a week I'm in my lab developing imaging tools to try and understand how diseases develop in the eye. And so a lot of the talk today that I'll give will kind of leverage on some of the existing imaging technologies that are available in our clinics that allow us to manage diabetic retinopathy. As with any talk, we always have to start off by saying how big of a problem diabetic diseases across the world are. And they really are just a huge problem. Can you imagine 500 million people in the next decade or so having this across the world? That's just an incredible population. It's more than the entire United States population suffering from diabetes. And it's just because their bodies cannot regulate their blood sugars. And that causes problems throughout the whole body. And in this diagram, we can see that it affects every single organ system from the brain down to the stomach and kidneys. And tonight I'll be focusing primarily on what we see in the eyes. One of the nicest things about the eyes is we actually can look directly at the microvascular pathology. In other words, the pathology that's affecting the smallest blood vessels in the whole body. And just because we can see it in the eyes, we can get a sense of what's actually happening in the kidneys or in the stomach, in the lungs, and in the brain, and in the heart and other organ systems as well. So when it comes to vision, of course, many of us have driven down freeways and enjoyed a good clear view of the signs in front of us, the cars well ahead of us, what's coming in from either side of the road. And that's the typical image that we function in our lives. And like a camera, the eye has a similar function. A camera has a lens at the front of the camera, and another lens which them in combination focuses an image onto a film or onto a CCD or CMOS sensor inside the camera, and creates this what we could in older days thought of being the negative image. But the eye is not exactly the same. It has a lot of similarities anatomically. We have a cornea at the front of the eye and a lens inside the eye. And both of these two lenses in combination focus this image onto the retina, which is the first neurological tissue that takes that light, turns it into neurochemical signals that are then sent back to the brain. And that's how we perceive light and images. The reality is that our eyes aren't exactly like a camera and that we have very high acuity in our central vision, but it becomes much more blurred in the peripheral vision. And the peripheral vision is very sensitive to movement. That's why, when we're driving down the freeway, we can maybe see someone running into the street, or an animal or deer. Um, this is the actual vision that we have, this kind of very high acuity central vision and more peripheral vision. And the central vision is what's typically the thing that makes people come in with diabetic retinopathy or macular degeneration, and more commonly age-related disease. When people lose the ability to see faces or read clearly, they realize that there's a real problem. And so in diabetic retinopathy is often is what brings them to our clinic. The peripheral part of the visual field is what we typically think of as being affected in diseases like glaucoma, open angle glaucoma, for example. So, and when the view that we see with our eyes becomes kind of hazy and blurry and darker, then we think of cataract, and that's a generalized degradation of the image. So diabetic eye disease actually affects all parts of the eye, as it does all parts of the body. It can cause severe dry eye, and actually people won't even necessarily know that their eyes are dry because the nerves that allow us to feel the surface of our eye can die because they lose their blood flow. And so severe dry eye can result from diabetes. It's called neurotrophic keratitis. I'm not going to focus a lot of time on dry eye tonight. I'll mention a little bit about cataracts, and that's the next part of the eye that's commonly affected in diabetes. We typically think of cataract surgery as occurring in people over the age of 60 or 65, but I've done cataract surgery in a 25-year-old, who had type 1 diabetes. I did that when I was a resident, and they had lost their vision, and cataract surgery restored their vision. And then, of course, diabetic retinopathy, which I'll spend a little bit more time talking about, as that's my area of expertise. So cataracts are where we lose the ability for light to be focused by the complex of lenses at the front of the eye onto the retina. And so less light reaches the retina, and it's more blurry and scattered. And we have 10 cataract surgeons at our eye institute. All of them are excellent. So we are routinely sending patients who have diabetes to our cataract surgeons to try and restore some vision if the cataracts have become sufficiently advanced to cause loss of vision. So what does a cataract look actually in a patient? If you dilate a patient's pupils and make them much larger, you can see in this patient's left eye there's no cataract, but in the right eye there's this milky, creamy looking thing that stops the light from entering the eye. And there's all different flavors of cataracts with different appearances. But the more common ones that we think of in diabetes are something that would look like the one in the top left-hand corner or the bottom right-hand corner of the screen. These other ones are typically associated with unique inherited metabolic disorders that can make them have these kind of really beautiful appearances. And how does the cataract degrade our vision? Well, you can have glare from cars' lights at nighttime, and so you can see the glare effect with halos around lights and kind of a scattering of light. But if you didn't have a cataract, you would have much less glare. Cataracts can cause foggy vision, where you take a beautiful scene like this and turn it into a very blurry vision, very blurry scene, or they can take the scene and actually just degrade the vibrance of colors. So you can have multiple levels of vision decline, even if you still can have very high acuity vision, 20/20 vision, but the quality of the vision that you see might be degraded as well. So in cataract surgery, the goal is to replace this cataractous lens with a new lens. And so what the cataract surgeons will do is they will enter through the front part of the eye, through the cornea, and they'll make a small opening in this very thin bag that holds the cataract inside the eye. And they'll remove it using high ultrasound energy, and then actually break it up into small pieces and kind of suck the broken pieces out of the eye. And after that's been removed, the bag is left empty, and they immediately place in a plastic lens that looks like this if you look at it from the front. And that sits in the front of the eye And it's a clear plastic lens that you have for the rest of your life, and that restores people's vision if they have cataract, whether it be from diabetes or not. And again, these are the cataract surgeons that I work with. In diabetic retinopathy, people who have diabetes will typically see a retina specialist to screen for diabetic retinopathy, or any ophthalmologist can do it actually. But once they have diabetic retinopathy, they'll see someone like the six of us that are at UCI. And so, how do we examine the retina? Well, I've told you that the retina is this wallpaper that covers the inner side of the inside wall of the eye, and we can take photographs of it like this. This is a 200-degree wide field, ultra wide field color image of the retina. So this is the optic nerve over here, and this is the fovea, the central part of the vision, the part that allows us to see faces and read very small text. And then the peripheral vision is provided by all the peripheral parts of the retina over here. But we're able to take these pictures routinely, and this is how we can see diabetic retinopathy in a picture. But we don't always get pictures. We'll usually dilate a person's eye and look inside the eye with a series of microscopes that we use in the clinic too. So again, this is the anatomy inside the eye. This is the back of the eye where the macula is in the central part of the back of the eye, and then the peripheral retina provides the peripheral vision. We can also look very closely at the macula, the central part of the vision. And if we wanted to look at it in cross-section, we can do that routinely in clinic. And we can simply use a scanning laser system that's not as simple as I just said it is, but it's really a remarkable technology that has revolutionized the ways that we can preserve people's vision and understand the diseases that cause reversible or irreversible vision loss. And so what we see here is a cross-section of the back of the eye, where this is the fovea, the central part of the vision is provided by the fovea. This is only 500 microns, half a millimeter across, that provides half of the vision that gets back to our brain. Everything that, as you go further away from the central fovea, you have your peripheral vision. And all this information that's provided by this retina that we see as this layered cake, this cross-sectional layer of neurological tissue, is sent through the optic nerve as we see over here, and that goes back to the brain where we perceive the neurochemical signals as vision. So, like I said, the eye is incredible because we can see the microvascular elements of diabetes. We can look at the disease face on. So this is an example of a fundus photograph, actually my eye. And if we zoom in, we see the macula and the fovea. We zoom in a little bit further on the fovea. We zoom in even further on the fovea. And within this blurry image here, there are microcapillaries that are only a few microns or tens of microns in diameter that allow blood to flow and keep the tissue that turns light into a neurochemical signal alive. And we can, if we look under a pathology slide, we can see all this network of very small, fine capillaries, and they have all these little blue dots along them. And those are actually the cells that make the tubes that are the capillaries that allow red blood cells and white blood cells to flow through these very small channels. And this is a normal eye. So we have normal capillaries where we have endothelial cells. These long blue things are the nuclei of those cells. And then the outside of these tubes are these pericytes. They support the capillaries. They're basically a support network of cells that keep the cells functioning and allow their structure to remain normal. This is actually a histological side of a dog, but it's not too different from what it would look like in a human. In diabetes, we have a very big difference. You see this long tube over here with no blue dots. There's no cells along there anymore. So that blood vessel no longer functions. It's a capillary that has died. And sometimes we see these outpouchings, these aneurysms, so a little kind of like a balloon budding from the side of the vessel. And these aneurysms can leak serum, the liquid part of blood, into the retina, and that can create swelling of the retina and vision loss. So we see a lot of loss of cells, and even the cells that support the blood vessels die as well, these pericyte ghosts, as we see here. So the blood flow in the fovea is actually, there is no blood flow in the fovea. The fovea is part of the retina that's supposed to give us our clearest vision. And if you had blood flow there, light wouldn't be able to pass through the blood vessels and you'd have poor vision. So there's actually normally no capillaries right in the central fovea, but you can see this is an actual image of a patient that is completely non-invasive. We can look at the capillaries using these scanning laser technologies on a routine basis. It takes about 15 seconds to get an image like this. And we can look at this really fine, lacy reticular network of capillaries. But in diabetes, here's that photograph of the retina. You saw some of these in Dr. Yang's talk, where you see this net of blood vessels growing on the surface of the retina. These are clearly big problems, big changes from the normal appearance on the top left-hand corner. And you can see little aneurysms and hemorrhages on the surface of the retina as well. But if we look in at the fovea, this part that has no blood vessels, and the capillaries surrounding it, there's a massive loss of cells of capillaries. So we can actually look in patients at the loss of capillaries. And actually, even in people who have perfect blood glucose control, I have a patient who's had perfect blood glucose control for 50 plus years. They're in their 70s. They're type 1 diabetic. They can have very small losses, not as profound as this, but even with good blood glucose control, there can be very, very small changes and loss of normal capillary flow. But when you have profound loss like this, you have profound loss of vision as well. So these people who are well controlled, they can have no effect on their vision at all, which is the ultimate goal is to not have any vision loss. So if you look at the anatomy of the fovea, we've seen these cross-sectional layered images of the retina. And in diabetes, when you have aneurysms and blood vessels that can leak the liquid part of the blood supply, you can have swelling of the retina. And this is what the swelling looks like. So when a person's fovea is swollen like this, as opposed to what it looks like on the bottom left, there's meaningful vision loss. They can have loss of acuity, they can have loss of contrast in their vision, loss of color, they can have distortion of the vision. And that's where we really absolutely have to intervene to try and restore vision and recuperate vision. Even though we can't restore complete normal anatomy, it is permanent blood vessel damage that occurs, not only in the eyes, but throughout the whole body when someone's in this kind of situation. And we can inject a dye inside the blood vessels. We can put a needle into a vein in your arm and inject this dye into your arm. And that dye circulates throughout your whole body, it flows through your blood throughout your whole body. And we can look at the blood flow in the eye, all these white retinal arteries and veins, arterioles and veins, venules that you see on the surface of the retina here. But in diabetes, you see a profound difference. You see where these new blood vessels have grown as these bright white areas. You can see how things are all dark in this peripheral part of the retina. That's where the capillaries are gone. And so this type of patient will have a very severe risk of permanent vision loss. So they need urgent care. And and you can also see on these non-invasive imaging tools, you can see the loss of normal, this kind of rich network is kind of gray in appearance here, but look, everything looks very dark on this image here because the capillaries have been damaged by high blood sugar levels. So not everybody who has diabetes has the worst type of diabetic retinopathy. It's graded according to its severity. We have non-proliferative diabetic retinopathy. That's diabetic retinopathy with no new blood vessels that have grown on the surface of the retina, and proliferative diabetic retinopathy, where new blood vessels have grown. And the proliferative type of diabetic retinopathy is the type that has the highest risk of permanent vision loss. Within non-proliferative diabetic retinopathy, we have mild all the way to very severe. And in proliferative, we have standard proliferative diabetic retinopathy or high risk proliferative diabetic retinopathy for vision loss. Here's an example of mild diabetic retinopathy, not too much looking unusual, but you can see as we sequentially step through these images and as the retinopathy increases in severity, the degree to which the images get worse is much more apparent. So what do we do in all of these cases? Well, we have to monitor people very carefully because people who look like this person with severe diabetic retinopathy have nearly a 50% chance of having proliferative diabetic retinopathy in just a 1-year time period. And people who have severe diabetic retinopathy have a 15% chance of getting proliferative diabetic retinopathy in 1 year. So as Dr. Yang has mentioned throughout his talk, it is the most important thing is to counsel people on blood glucose, high blood pressure, and their lipid control. Basically make sure that their overall metabolic control is favorable to supporting survival of blood vessels throughout the whole body to prevent the risk of heart attack and stroke in particular as well. We monitor people with eye exams. Someone with mild diabetic retinopathy might be seen every 9 months. Someone with severe diabetic retinopathy will be seen every 4 weeks to 3 months. And if proliferative diabetic retinopathy, will be following them very closely on a monthly basis while providing them treatment. In all stages of diabetic retinopathy, we can consider putting a medication directly into the eyeball, where we stick a very small needle inside the eye through the white part of the eye into the central part of the eye and inject a small volume of medication. In people with very severe diabetic retinopathy and beyond, we can consider laser or definitely use laser to treat the retina to try and prevent the diabetic retinopathy from even getting worse and having permanent vision loss. People with high-risk proliferative diabetic retinopathy might need to have surgery, and we routinely do surgery for these types of patients. So what are all these different treatment options? I've talked about injections of medication into the eye, mentioned laser, and I've mentioned surgery. So I'll talk about each of them briefly. So someone who has this kind of swelling of their macula and their fovea needs to have injections of medication into the eye to try and get rid of the swelling. So here's somebody that I gave care to up in Los Angeles County back, over 10 years ago when I was a resident. And I injected this patient with medication. You can see on this color picture, there's maybe some little red spots you can appreciate. But when you look at the thickness map, kind of a topographical map of the thickness of the retina, where the white part is the high part of the mountain, this very thick part of retina up here, we can see where the retina is thickened as if we were looking into the eye. And after some injections, this is over a year of treatment. There is still a little bit of swelling. You can see a little black spot over here, and there's still some thickening outside of the central vision, but the person has normalized their retinal structure, and their vision does improve. Their vision can be 2400, meaning that they can see only a very big E on the chart and something like this, and they can go back to something like 2025 or 2030. We can restore people's vision. Again, we can't restore normal anatomy once the damage has been done, but we can at least try to control the vision loss that's associated with that damage to the anatomy. So when someone has proliferative diabetic retinopathy, we actually use a laser, and we shine the laser through the front of the eye to the back of the eye to the peripheral parts of the retina, and we make little focal burns. And actually, here's me treating somebody at one of the free eye clinics in Orange County. We did receive permission from this patient, even though you can't tell who it is, to share this picture. But what I'm doing here is I have a laser coming out of this headset that I'm looking through a lens that I'm holding, and I'm focusing it into the eye. This is not surgery; it's precision optical placement of high energies of doses of light that make these little focal burns of the retina. And those focal burns actually damage the retina permanently. But the retina that's in these locations where we're burning it aren't receiving blood flow. And so they're under extreme stress. They're releasing chemicals that I tell my patients it's like a fertilizer. They're constantly releasing this fertilizer that says, please help me. I can't breathe. I'm not getting any nutrients because the blood vessels are damaged. And that fertilizer causes the new blood vessels to grow on the surface of the retina and on the surface of the iris at the front of the eye. And that can cause permanent vision loss from a number of mechanisms. So we actually destroy the retina as little as possible these days, but we actually burn the retina so that these new blood vessels won't cause permanent vision loss. So we can at least try to preserve someone's central vision. And so here's an example of someone who has a net of new blood vessels growing over the optic nerve. You can see them very clearly. These very small, fine, lacy vessels are not normal. The larger vessels are the normal ones. And you'll see that there are laser scars in the second image, these little brown spots. And you can see that just with laser, those lacy reticular new blood vessels regress. And so this is actually was the mainstay of preserving people's vision for the last 40, 50 years to try and prevent permanent vision loss. And now with these injectable medications inside the eye, we can do a combination of laser, so we have to use less laser, and we can use the injectable medications to try and control these complications of diabetes. So here's an example of a patient of mine that I gave care to when I first started attending at UC Irvine. And we can see in this image lots of yellow spots where we see protein and lipid leaking into the retina, and lots of red spots where there's actually microhemorrhages on the surface of the retina. And when we do an angiogram, we can see these blood vessels that are leaking, new blood vessels growing on the surface of the retina. And in this person, they had no idea they had a problem. They're 20/20. just like most people are when they're born. And even their central vision looked completely normal. But they had a real problem. They were at a very high risk of having permanent vision loss because of new blood vessels growing throughout the surface of the retina. And so after laser treatment, we were able to make these blood vessels regress to some degree. They don't go away completely, but we can at least preserve that person's vision. And after, 2 years of treatment, we were able to keep that person seeing 20/20. Sometimes the new blood vessels grow so aggressively and they contract and they tear the retina, they pull the retina off, and you people have permanent vision loss. They also can bleed. These new blood vessels are very willing to bleed because they're not normal blood vessels. And so in these situations, we might have to do surgery where we actually place pencil lead size instruments through the white part of the eye, and we remove the jelly inside the eye, remove the blood that's in that jelly, and then we systematically remove scar tissue from the surface of the retina. And so here's an example of a patient, um, actually the same patient who in their other eyes, 20/20, not aware of any problems, coming in for routine screening, and a few months later, they have bleeding on the surface of the retina inside the eye. And you can see this blood everywhere. And actually, in the cross-sectional image, I'll go back to this. You can see this is where the central vision is. This is the fovea. And there's all this blood on the surface of the retina in the jelly. And this person still does 20/20, but they know they have a problem because a large portion of their peripheral vision is obscured. And then eventually, they can even have 20/25 vision, almost what one would consider normal vision. But the quality of that vision is incredibly poor. They have a hard time navigating with that eye and seeing anything in the periphery because there's blood covering everything in the peripheral retina. So we, in this case, did surgery, removed all the blood inside the eye, gave complete laser treatment to the peripheral parts of the retina, and were able to preserve their 20/20 vision in this eye. So some of the newer thoughts for diabetic retinopathy are looking at the earlier stages. I'm going to go and recapitulate what Dr. Yang has said and what I've said a couple times. The most important thing for all of these patients is diabetes control, because we can be doing things to try and control vision loss, but that doesn't stop the progression of kidney disease, the progression of microvascular disease in the heart that can have heart attacks, the microvascular disease in the brain that can have strokes. So blood glucose control, blood pressure control remain the most important thing that a person with diabetes can do, even when they have these more severe stages of retinopathy, disease in the eye. Some of the newer thinking is considering injections at the earlier stages of the disease before the risk of vision loss is much lower. And it hasn't been widely adopted. It's hard to motivate ourselves and our patients to consider having a needle put into the eye to try and control disease at the early stages when it has a low risk of progressing to advanced disease, especially if they're controlling their blood sugar very well. But there are rare circumstances where we might want to consider that. And so I had a patient with type 1 diabetes, 31-year-old female. She wanted to have a family. And we know that when people are pregnant, their ability to control blood sugar is much more challenging. So in these cases, if I have someone who comes in and has, showing these more black and white images, they have these little spots of hemorrhages all throughout their retina. What I will recommend in these rare circumstances is treatment to try and minimize the severity of the disease, make it even less than mild or moderate diabetic retinopathy, take it back to pre or mild diabetic retinopathy before they become pregnant, because that way their retina is in a much better condition if they have trouble controlling their blood sugar during pregnancy. Sadly, I've seen many young women, not many, but there's a good number of faces that I can think off the top of my head who go blind because they become pregnant with poorly controlled diabetes. And if we can make sure that these patients are followed closely throughout their pregnancy, controlled with have tight blood glucose control with their primary care and endocrinology, then they don't have to lose vision during their pregnancy. So in summary, we see these heat maps of very bad diseases throughout the world. Just imagine 500 million people in the next 10 years around the world. Incredible. We have these different stages of disease that all require different levels of treatment. Injections, laser, and surgery might be needed from an ophthalmologist standpoint. And prevention remains the most important thing that we can do for any of these patients. This is a picture of our eye institute at UC Irvine, and these are the faculty. A third of them are researchers, and 2/3 of them are clinical faculty And yeah, invite any questions at this point.
There's one in the chat, Dr. Browne. Are cataracts inherited or everyone eventually get them due to aging? How many years before it develops and requires surgery? At that point, if you don't do surgery, you cannot see?
Yeah, so everyone, if you live long enough, will get a cataract, whether it's visually significant. In other words, significance is directly proportional to the person. Not everybody is bothered by a cataract. My grandmother lived to 93. She definitely had a cataract. She probably wasn't 20/20. She may have been 20/40 at the end of her life, but she was never bothered. She was able to perform the activities of life that she wanted to do, and she never wanted cataract surgery. Whereas there are most people actually have visual impairment that bothers them. And so uh, the short answer to the question is yes, everybody gets them. Some people get them at an earlier age than others. And if you have diabetes, you'll get them at a much earlier age than people without diabetes. Um, if you don't do surgery, well, the cataract will continue to progress as you age. And whether it visually impairs you to a point that you're bothered by the vision loss, um, it will be the determining factors whether you have surgery. Most people don't have complete loss of vision because of cataracts, and certainly vision can be restored with cataract surgery. So I see another question here. I had glaucoma surgery on both eyes, and cataract developed quickly following the glaucoma surgery. Is this normal? Yeah, any invasive procedure in the eye, like glaucoma surgery, does accelerate the formation of cataract. So, when I do surgery on people who have not had cataract surgery, I always tell them that that the probability of them developing cataracts is much higher, and if they're over the age of 50, within 5 years, they probably will require cataract surgery. So what are the first symptoms of it says DPR, but I think you mean PDR, proliferative diabetic retinopathy. And the reality is there don't have to be any symptoms at all. Usually when people are coming into my clinic and they have symptoms, it can be blurriness of the vision, it can be floaters in the vision, it can just be I'm just not seeing the way that I want to be able to see. There can be any number of symptoms. People could come in even with retinal detachments from severe proliferative diabetic retinopathy. Um, so the reality is a lot of people don't have symptoms, and it's the symptoms that cause them to come in and realize they have proliferative diabetic retinopathy.
Thank you so much for joining us tonight and have a good evening.
Thank you, everybody.